చెప్తున్నారు మేడ పైన.
Hi, good evening all. I welcome you all to the fourth session of case-based discussion by Andhra Hospitals. Welcome you all once again. And today we have a case-based discussion about developmental behavioral problems in the children, which are increasing rampantly in the post-COVID era. We have been encountered many of the children in the post-COVID era coming with a lot of behavioral problems, mainly autism. So we thought it will be relevant for the physician practitioners to have an idea about this developmental behavioral problems, which are quite common in children, but very rarely diagnosed and referred to the appropriate places where the treatment can be provided for this kind of children. And even my PG days, I am very afraid to deal with this kind of children, and even not bother to read these topics in the textbooks as well. So I hope Dr. Ashita, who is our developmental behavioral pediatrician, she completed her fellowship, IAP fellowship in developmental behavioral pediatrics from New Horizons Child Development Center, Bombay, from Dr. Samit Dalwai, a pioneer in developmental behavioral pediatrics in India. I hope she will enlighten us with a few problems regarding developmental behavioral pediatrics, which are commonly encountered in children. So over to you, Dr. Ashita.
Hello, good evening everyone. I'm Dr. Ashita Jannalagadda. I completed my MD Pediatrics from DY Patil, Pune, and then I've done a fellowship in Developmental and Behavioral Pediatrics with Dr. Samit Dalwai at New Horizons Hospital, Mumbai. Currently, I'm working with Andhra Hospitals as a Developmental and Behavioral Pediatrician. Today, I'm going to discuss few case scenarios where I have encountered after working with Andhra hospitals. So I want active participation from all of you. So just let me know if I'm going fast or slow. If you have any doubts, please put it in chat box so that we can take it at the last. So why we have chosen this topic, as Dr. Ravant has already spoken, because of COVID, after post-lockdown, there are so many developmental issues that are being addressed in current OPDs, pediatric OPDs. So that's why we have taken this topic for today. So I'm directly jumping to the case scenarios. The first case scenario is a 3-year-old female child presented with a complaint of hyperactivity, restlessness. She does not speak any meaningful words, but repeats few sentences. Whatever the parents are telling, she's repeating the few sentences. And with fleeting eye contact, there is toe walking, and also parents also has observed that there is that she's doing hand clapping when she gets excited. And while playing with the toys, she puts stacks of all the toys in a line when she's playing with all the toys. So these are the complaints they have brought the child with. So how will you proceed further if the similar complaints are brought up to you with a child, in a child? It's okay if you go wrong also, but I just wanted to know what you guys are exactly thinking about the case scenario. So kindly give your inputs. Okay, chat. Okay. What else you want to ask the parents regarding any history or anything? Okay. Why do you thought of ADHD? What are the symptoms those are supporting ADHD in this scenario? So does all the hyperactive restlessness or fleeting eye contact will give you, or you want to ask any other questions? Okay. So we need to have a detailed history and physical evaluation. Sorry. So we need to have a detailed history and physical evaluation. Why detailed developmental history or birth history? We have to rule out any global developmental delay or any seizure disorders or any neuroregression symptoms, anything else from the history we can get it. So we can rule out those disorders. And physical evaluation to rule out any dysmorphic features and neurocutaneous markers to rule out syndromes like Rett syndrome, Fragile X, or any other syndromes. And the investigations we have to do here, and also developmental history will rule out any other birth histories, asphyxias, anything for global developmental delay. So we have to conduct hearing evaluation also. These are the main investigations we'll do with this kind of symptoms. So for this case, uneventful antenatal, natal and postnatal birth history was there. Speech delay was there in developmental domain, and there were no neurocutaneous markers. BERA was already done and it was normal. So what are your differential diagnosis that will come for this complaints? So now I have given you the chief complaints and also some insights in history and evaluation. Okay, why it is autism? What are the features that are supporting the autism in this case? As the diagnosis is autism, yeah. So the basic point, there are two core features that are supporting autism here. One is fleeting eye contact and also hand flapping and staggering up of the dots in the line. So the main two domains that are affected here is social communication and interaction. There is no eye contact and there is speech delay, gross speech delay in this child. And also there is hand flapping, repetitive movements and restricted behaviors are also observed in this child. So the diagnosis here is autism. It's autism. It comes under autism spectrum disorder. So coming to the next case scenario, there is a 20 months old child brought with complaints of good response to name call, good eye contact, and communication, and she also get along with the so what are your differential, and there is uneven antenatal birth and postnatal speech delay is present. There are no dysmorphic features. What could be the diagnosis for this? So for this complaints, what could be the differential diagnosis? The child is able to point and do the, why it could be hearing loss? Why not autism? Yes, the diagnosis is hearing impairment. Yes, right. So there are no dysmorphic features, but there is gross speech, but there is good eye contact, and also the child is using pointing and gestures for communication. So there is good social interaction. There are no repetitive behaviors, and only there is a speech delay without any dysmorphic features and normal history. So that could be leading to our hearing impairment. And it is very necessary, it is very important to screen all the children, neonates, especially during their birth, because hearing impairment is also a common behavioral issue that will be brought up and mistaken for many other developmental disorders. So in neonatal period for hearing, we can do OAE for screening. For 6 months to 2.5 years, we can do a visual reinforcement audiometry, and BERA we can do at any point of time. In older children, we can conduct pure tone audiometry. So if we recognize hearing impairment as early as possible, we can save the child, because vocabulary will be saved, and also the behavioral concerns will be reduced if the hearing impairment is diagnosed as early as possible. So coming to the next case scenario, a 27 months old male child was brought with the complaints of poor response to name call, not following any commands, and there is fleeting eye contact. But the child can say few nursery rhymes or A to Z alphabets or 1 to 50 number pre-lockdown era. And then after lockdown, the child has completely stopped telling anything, and there was excessive screen time, and whatever the child is talking, she's talking in, the child was talking in the typical YouTube language, whatever YouTube channel he was watching, that was the slang he was using to communicate with the parents. So there was hyperactivity, and also the toe walking was there. So uneventful, same uneventful antenatal and or postnatal history. In developmental history, there was gross speech delay. There were no neurocutaneous markers, and BERA was normal. So what could be the differential diagnosis? Yes, the copying is there. That is what we call it as echolalia. That's what I'm trying to tell you. So what could be the differential diagnosis, or what could be the diagnosis here? After excessive screen time, even the child is more aloof. Even having a proper eye contact, or not even zero response to name call, zero. So what could be the diagnosis here? Screen dependency is a kind of not the diagnosis. No, not self-autonomous behavior. Yes, it is autism, but worsened due to lockdown because of a lot of screen time. The parents got busy, and the social interaction has completely gone down. Even the fleeting eye contact was not there. It was there previous lockdown, but now it was not there. And lot of echolalia and parrot talking is there. Like the child is using YouTube language to even during echolalia. So it is autism spectrum disorder only. It's a kind of different kind of presentation post-COVID we are observing in a lot of children. So next comes the case. A 7-year-old male child came with the complaints of restlessness, poor interaction with peers, is using meaningless words. There is poor and also the complaints of poor academics, complaints from school, aggression towards caregivers, and he jumps when he gets excited, and there are rocking moments like to and fro moments spinning. So what could be the diagnosis? Yes, ADHD, and anything else you can identify from the history or the complaints? He is using meaningless words in between. There are rocking moments. There is poor interaction with peers is also there. Anything else other than ADHD we are missing here? And what are the points that are supportive of ADHD here? What are the points that are supportive of ADHD? Whoever has answered ADHD, can you please put the points that are in supportive of ADHD? Complaints or features, what symptoms?
Excited.
Poor academics, complaints from school.
Okay.
Poor interaction with peers.
Poor interaction with peers. Then jumping when excited can also come under repetitive movements. Rocking movements are also repetitive movements. They are not aggression. Yes. So the diagnosis is autism with comorbidity ADHD. Autism supportive features are rocking movements, poor interaction with peers, and also using meaningless words. Later, the child has developed ADHD, restlessness and poor academics, complaints from the school, aggression, and also jumping when excited. It's hyperactivity type of ADHD. So these are the few case scenarios I have seen when I started practicing here. So today I'm going to discuss some part of management in autism spectrum disorder. So management of autism spectrum disorder mainly depends on diagnosing the part, that is by a history, examination, and also the observation of behavior. When we have to suspect autism spectrum, we have to suspect in the children who has abnormalities in social interaction, social communication, and also if there are any restricted repetitive patterns of behavior interests and activities. In these kind of children, we can suspect autism spectrum disorders. So if there are abnormalities in this criteria, we have to check whether the child is meeting the criteria of DSM-5 for autism spectrum. So this is DSM-5 criteria for ASD. You can get it online. So the two main domains are social communication and social interaction. The other domain is restricted repetitive patterns of behavior interest. So these are the two main domains, two main criteria that should meet for DSM-5 ASD. And what are all the differentials we think when we have the child with similar complaints? We have to think of GDD. So that's why I told you about the detailed history and also physical examination. Intellectual disabilities sometimes may come up with the similar complaints like not getting along with peers or poor interaction. Social communication disorder alone means only the domain of social interaction, like they are good with, there is no gross speech delay, but the child is not very well getting along with the parents or siblings or any peers or any other thing. Developmental language disorders, sometimes multiple languages they are using. If intellectually disabled, then the child may have developmental language disorder. Hearing impairment, I have shown you one case scenario. Rett syndrome, anxiety disorder, and obsessive compulsive disorder are the differential diagnosis for ASD. So have to evaluate when you have a complaints in the child. There are screening tools and are also diagnostic tools. Screening tools include MCHAT, GARS, which is known as Gilliam Autism Rating Scale, Social Communication Questionnaire, Childhood Autism Rating Scale, and also Social Responsive Scale. These are the screening tools. And the diagnostics tools are autism diagnostic interview and autism diagnostic observation schedule. And what are all the other assessments we'll do? We'll assess their IQ through Vinland Social Maturity Scale, Vinland Adaptive Behavioral Scale, and also development assessment for Indian infants. So MCHAT is very easy and you can do it in a regular office practice. So this is all we can do. It's a screening tool. MCHAT R is MCHAT revised. So it is a screening tool. It is easily available online and it is free of cost. You can just type MCHAT R on Google and you'll get a website. So if you go there, you can, that MCHAT consists of 20 questions, yes or no questions. So we generally ask the parents. So it will be in yes or no format. And it can be finished off in 5 to 10 minutes. For age group 16 to 30 months, we have to apply this MCHAT. So how to interpret the MCHAT? If the results are between 0 to 2, it is low risk. 3 to 7, then it is medium risk. 8 to 20, high risk. So MCHAT not only screen autism, but it also screens global developmental delay, because it has two more questions like does the child can walk, and also if do you think your child is deaf. So all these two questions are also covered in that 20 questions. So if there is any result, if you get any result between these scores, then you can suspect a developmental delay and you can evaluate further. So this is how MCHAT looks. So these are the 20 questions they'll have, yes or no. So you should ask the parent to answer in yes or no, and you should pick, and it hardly takes 5 to 10 minutes. You can do it when the child comes to you for immunization, or when the child comes with any other complaints to your normal OPD practice or to your OPDs. So in autism, what are all the investigations we can do? CBC and thyroid function to rule out any hypothyroidism or any other things. If indicated, like any dysmorphic features or in history, if you have any seizures or anything, then EEG, MRI, brain, you can do. You can go for a genetic test when there are dysmorphic features. For male child, you can always ask if the history supportive of any developmental delay in the parent, in the family history, any abortions or any other thing, then you can suggest Frasilex for a male child and MECP2 for Rett syndrome to rule out Rett syndrome in female child. So what are all the comorbidities we can see in ASD, ADHD, aggression, intellectual disability, obsessive compulsive disorder? What are all the differentials we kept? They can occur as a comorbidity too. So anxiety and depression, these are all the comorbidities. And also malnutrition, constipation, sleep disturbances, and dental problems are also common comorbidities we can see in all the developmental concerned child. So this we can treat it in our normal routine practice also. So that is the reason I have mentioned it separately. So how to manage a ASD child? So the general principles include so the management include we should start the intervention as early as possible, and it should be specific. What do you mean by specific? It is like individualized. For every child it is different, so we have to always assess where the child lies in his developmental quotient, and everything we have to calculate, and we have to see where developmentally where the child is, and then we have to structure a program. And it should be evidence based, like ABA, TEACH, all those things, but we cannot rely on stem cell therapies or any other diet therapies. That's the reason I have mentioned evidence based and structured. So we have to see the core deficits where the child has, and we have to structure a plan, and it should be interdisciplinary, and it includes all the behavioral therapy, occupational, speech, or the remedial education according to the age of the child. It should be interdisciplinary. It should not be symptom based. And so that is what the modalities are. There are two kinds, non-pharmacological and pharmacological. In non-pharmacological, we have to focus on 4 symptoms. And if there are any other sensory or behavioral concerns, and if the child is school going age, then we have to focus on the educational thing also. And in pharmacological thing, we have to address any other psychiatric or medical comorbidities, and any other comorbidities like aggression, depression, or OCDs. All those things can be treated pharmacologically, but those pharmacological treatments will not treat your core deficits. It treats your comorbidities. So this is how we'll manage. So we'll focus on core features, that is social communication and interaction, and RRBs, that is restricted repetitive patterns. And also if there are any associated features, because autistic child are more prone to this sensory concerns, like they are afraid to loud sounds, they can't tolerate darkness. All those sensory concerns need to be addressed. And also there will be, we can find a lot of sleep disturbances in this child. So all this should be considered in our management. And if at all any comorbid conditions that need to be treated, we should look after. And also the education part. So a good autism intervention program is based on the child chronological age, at what age he's coming to you and at what developmental level he or she is. And we have to focus on the specific strengths and weakness of the child, and also the family needs. We need to counsel the parent accordingly. So the program should be always 1:1, like child and therapist, not a group program, because every child will have a different features or different weakness and strengths, and it should be individualized for each child, as I told you, with an interdisciplinary team. So few tips for all of you. So first thing I want to tell you the red flag signs. because these are the common red flags you can see when the child comes to you for immunization. By 6 months, if the child is not having social smile or joyful expressions, it's a kind of red flag. By 12 months, if the child is not responding to name. By 14 months, if the child does not point at objects or shows interest. And by 16 months, if he's not even saying single word, or by 18 months, if he or she is not doing any pretend play. These are all the red flags we can keep in mind when the child comes to us for normal routine checkup. These are some common red flags like poor eye contact or any repetitive words or phrases, meaningless words, repeating meaningless words, or giving unrelated answers, or if there are any repetitive movements like flapping, rocking. All these are general red flags we can observe. And these are generally some of the myths that are associated with autism. It is not due to any lack of exposure or lockdown or excessive screen time. Yes, excessive screen time worsens autism, but it won't create any autism in the child, or it is not the primary reason. It is not a speech disorder, and it is not due to any multiple languages, or if the mother is speaking some language, father is from different language, that is the reason for autism. No. It is not due to any speech delay in father. It means father, if father has speaking late history or speech delay, that is not the reason. These are the myths, some of the myths that I want to address. So the take-home messages are developmental and behavioral concerns. They are increasing globally post-pandemic. So we need to take a detailed history and physical evaluation if there are any red flags if you are observing, or if they're bringing to you with any symptoms. So try to use MChat in your normal office practice. That will help to identify the developmental concerns. And also hearing assessment should be done in all speech delay, or at least neonatal evaluation for hearing should be done during the delivery time. And if there are any developmental concern, holistic approach is more beneficial than individual or symptom-based therapies. Thank you. So if you have any questions, you can post in the chat box. So everybody understood autism spectrum disorder. Now you can treat all, at least identify the autistic children in your day-to-day practice. Do you have any questions? Please post it in the chat box.
Thank you, Ashwita. It's a very lucid presentation about developmental and behavioral problems. And I have a few queries regarding autism. And so what is your experience about the outcome of children with autism? Is there any certain factors which can predict the outcome? So like younger the age, more the recovery. So is there any things like that so that you can enlighten us? So it will be helpful for the pediatricians so that they will not miss the autism.
So the outcome is better if we intervene as early as possible, the first thing, and changing the environment at home. And even there are some studies showing that male children has a better outcome than the female child who is autistic. But generally, considering the neuroplasticity till 5 years of age, if you are identifying the child at early ages, that will be a better outcome.
For the maximum, developmental wise scores, what the maximum score I can achieve if I come late? say I come at 6 years of age and I come at 3 years of age. So what are the maximum scores I can achieve at 3 years and 6 years?
So there is nothing like severity doesn't depend on your age or anything, sir. Actually, the scores are very individualized, and they are whatever scores we are giving till now, they are very individualized. Like it all depends upon that day what your parent is telling you and all the symptoms wise. So the score part is very individualized thing. So it is not like if a 3-year-old patient is coming to you, child is coming to you, he'll have a severe autism, and 6-year will have a less autistic rate. It all depends on the child and the way they are presenting to you. But yeah, it is not like age related score. It all depends. It is very individualized score. I hope I answered your question.
My question is that I'm asking how much maximum we can record a child. A severe autistic child, like developmental wise, is very low scores. Developmental scores or developmental behavior scores are very low, and by our treatment and by
you mean severely autistic child?
Yeah.
How much I can recover?
Yes, exactly. That's my point.
So, how early you are intervening, and how frequently they are taking the therapies, how much they are following with a pediatrician. Those are all the factors that will come into place. You can't tell like 90% I can recover the child or he will come back to normal developmental quotient. No, there will be a delay always, but it all depends on how the parents are taking it, how they are treating the child at home, and how frequently they are following up with the therapies and also the pediatrician. It doesn't depend on your age or it doesn't depend on your scores. It all depends upon how much frequently they are attending and how they are taking the treatment. Yes, autism runs in family. If a sibling has a autism, the next sibling, 5 to 20% chances are there. A study shows 5 to 20% there is a chance for the next sibling to get autism. So I hope I answered your question. So as I told you, we can't take individual. We are not treating symptom wise, right? We are treating the child holistically. So you are the one who is going to decide whether the speech therapy is important or not. If the child is presenting to you at a very early age, you will focus mainly on the deficits like social communication or social interaction part. So even if they withdraw speech therapy, yeah, there may be chances of going back to the same deficit again if the child is not taking the holistic approach. I can't tell you if the child is not taking the speech therapy, how much chances are there. As I told you, we are treating holistically. If the child is not on proper therapy, if they are withdrawing it, there might be chances of developing behavioral concerns when the child is growing. I hope I answered your question, Dr. Hima. Yeah, thank you.
If no more questions, we'll conclude this session. And thank you, Ashita, once again for your useful presentation. I hope everyone has got some pinch of points from your talk, and I think they'll practice tomorrow onwards. Thank you all. We'll conclude this.